So this chapter, we're going to be talking about the child with cardiovascular dysfunction, and there are many different types of dysfunctions that can happen, but we're just going to be focusing on the 4 different classifications and what that means. So 5 to 8 out of every 1,000 births can result in a child with cardiovascular dysfunction, and it's the major cause of death in the first year of life. Multiple factors can put infants at risk for congenital heart defects, including maternal illness during pregnancy or exposure to toxins. Infection, obviously drugs and alcohol, family history increases the risk, and chromosomal abnormalities also increases the risk for congenital heart defects. Ventricular septal defect is the most common, and those are kind of some fun facts, but we'll move on to the 4 different classifications. So first, we're going to cover increased pulmonary blood flow. So before we get into the actual defects, normally in our heart, we have a higher pressure on the left side of our heart compared to the right side. So with increased pulmonary blood flow with these defects here, blood shunts from the areas of high pressure to low pressure, aka the left side of the heart to the right side of the heart, because the left side has higher pressure. So this results in blood shunting from the left to the right and an increase in blood volume on the right side of the heart, which results in increased pulmonary blood flow, because the right side of my heart is the portion that pumps blood to my lungs. So if I have an increase in volume, clearly I have an increase in blood flow to my lungs. So what does this look like? So the 3 most common defects are ventricular septal defect, atrial septal defect, and the patent ductus arteriosus. So in VSD, there is a hole between the left and right ventricles. So this would allow for blood to flow from the left side to the right side of the heart. VSD, like I said in the previous slide, is one of the most common of the congenital heart defects. Atrial septal defect is probably one of those defects that can go unnoticed, or if somebody does have this, it doesn't really cause much of a clinical problem as some of the other defects that we will talk about. So when I have blood shunted from the left to the right side of the heart, it means that my left ventricle is going to have to pump harder depending on the size, because my left ventricle is going to try to maintain my cardiac output. So it's going to pump harder to maintain a normal ejection fraction or normal stroke volume, and therefore a normal cardiac output. So depending on how much blood is being shunted really depends on the clinical symptoms that we get. In addition, my lungs are also going to have to start working harder because of the increase in volume that my lungs are now receiving. So patent ductus arteriosus, or it's PDA, is the vessel that connects the aorta to the pulmonary arteries, and this is present in fetal circulation. And as soon as we are born, this vessel, due to increase in pressures within the aorta, winds up closing off. So one of the defects is this stays open, which leads from the blood from the aorta being shunted into the pulmonary arteries and therefore increasing the blood flow to the lungs. So for treatment of VSD and ASD, since these are fairly common, there are surgeries that can either patch over those holes, for lack of better words, or sometimes they wind up closing up on their own. So if I was born with a small atrial septal defect, sometimes they just heal up over time if it's not causing any symptoms, or if that hole is small enough. In addition, sometimes the ASD and VSD are detected because of a murmur that is heard on the infant. And then they will go for an echocardiogram that will show blood flow and try to detect if there's any septal defects. So VSD and ASD are fairly, they're treated fairly simply, and they have a very good prognosis. Patent ductus arteriosus also has a pretty good prognosis. We can give medication called indomethacin, which is a prostaglandin inhibitor or a hormone that helps to close off that extra blood vessel. If they have large ventricular septal defects or ASDs, what can happen is infants wind up in heart failure because the left side of the heart is having to work hard because it doesn't have enough volume, trying to meet cardiac output needs. And the lungs are also affected because they receive a higher volume, and it can damage the blood vessels in our pulmonary system and lead to pulmonary hypertension, heart failure symptoms, and arrhythmias from changing the size of the heart. So there can be complications from this. So obstructive defects is just what it sounds like. There's some sort of an obstruction that is preventing blood flow. So with aortic stenosis, it is a very stiff aortic valve. So the left ventricle will have to work extra hard and hypertrophy and dilate to try to pump blood out through that aortic valve to meet cardiac output needs. Pulmonic stenosis, it's the same thing except on the other side of the heart. So the right ventricle will have to pump extra hard and work extra hard to pump blood through the pulmonic valve because the orifice is so small because of the stenosis to try to get oxygenated blood back to the body. And coarctation of the aorta is a very narrowed constriction of the aorta. Depending on the degree of stenosis or the degree of the coarctation of the aorta depends on the symptoms that these infants will have. Aortic stenosis is probably one of the, if it's severely stenosed, does not have a very good prognosis. Many times because I'm not getting blood from my left ventricle out to my body, these patients or these infants have signs of decreased cardiac output. So they have very faint pulses, hypotension, poor feeding. A lot of times they have ventricular hypertrophy because they don't have the compensatory mechanisms that we have as adults. Their little heart muscles are sensitive to pressures and to changes. Many times patients, these little infants can have heart attacks because of we're not perfusing the heart as well. So with aortic stenosis, our coronary arteries that perfuse our heart, that main branch of the coronary artery that is delivering that oxygenated blood is just past our aortic valve. So not only am I not perfusing my body, but I'm also not perfusing my myocardium. Patients can have surgery. You can go in with a balloon angioplasty, but it's said that about 20% of infants will need surgery at a later date because they do have to fix that stenosis. Pulmonic stenosis, kind of the same thing, depending on the degree of stenosis. We can undergo a balloon angioplasty to help fix the stenosis. And coarctation of the aorta definitely needs surgery because I'm not able, depending on the degree of, how closed off that aorta is. If we don't get blood flow to our periphery, what happens when we don't get oxygenated blood to our tissues? Well, we start going from aerobic to anaerobic metabolism, producing lactic acid. I wind up with tissue necrosis and severe metabolic acidosis, which, can lead to death. So with these obstructive defects, depending on the degree, it can be pretty severe and infants can deteriorate quite rapidly. So when there is decreased pulmonary blood flow, blood has difficulty getting to the lungs, which results in increased pressure on the right side, which furthermore backs up into the systemic circulation Or if there is a different defect present with this, for example, in tetralogy of Fallot, there's 4 different defects. There's pulmonic stenosis, so blood has a difficulty from getting to the right ventricle out through the lungs. There's a ventricular septal defect, so blood flows because I'm having trouble getting blood flow through my pulmonic valve into my lungs. I have an increased pressure on the right side of my heart due to my right side trying to overcome that stenosis. So instead of that blood flow going from the body, with the ventricular septal defect, there's a hole between my ventricles, so in tetralogy of Fallot, so that blood flows back into the left side of my heart, that deoxygenated blood. So now I have a mixture of oxygenated and deoxygenated blood that's being delivered to my body. I also have, in tetralogy of Fallot, I have VSD, pulmonic stenosis, right ventricular hypertrophy, because my body's, that ventricle is trying to work really hard to pump blood to my lungs. And I also have this overriding aorta, which generally the aorta, with overriding aorta, the aorta is between the right and left ventricles. So it's overriding, or it's between both of those ventricles. So it's receiving half oxygenated and half deoxygenated blood. So these children are very acutely cyanotic, especially in the first year of life. So simple things such as feeding, crying, anything that's stressful can cause extreme exhaustion in infants. With tetralogy of Fallot, there's multiple surgeries that infants need to go through. Ideally, these surgeries are scheduled in the first year of life, but it depends on how severe the symptoms are, how stable the patient is. But we really want to prevent these children from going into heart failure and then having to deal with heart failure for the rest of their lives. So depending on the degree of pulmonic stenosis or the size of the ventricular septal defect, really depends on when these surgeries are scheduled, but it's usually multiple surgeries. For children who wind up not having very severe symptoms, wind up having these TET spells, T-E-T spells, where because they are cyanotic or they have some degree of cyanosis and hypoxemia, anything that's stressful, they'll wind up like passing out basically. And those are called TET spells, and that's specific for the tetralogy of Fallot. So anytime you see TET spells, think tetralogy of Fallot and decreased pulmonary blood flow. So I'm not getting, oxygenated blood out to my body, and I'm also not perfusing my lungs very well with oxygen or blood flow to become oxygenated. So some of the heart failure assessments that we'll see are very similar to those of the adult patient. So I have my tachypnea, tachycardia, dyspnea. I can have weight gain in children, and different from children are the retractions, or different from adults, retractions, nasal flaring, cyanosis, and grunting. So the whole goal is to prevent infants from going into heart failure. So let's talk about some of the treatments on our next slide, some of the interventions. So our goals for heart failure, or children with heart failure, are pretty much the same as they would be for our adult patients. We want to increase cardiac contractility, decrease preload, decrease afterload, and preserve oxygen or conserve oxygen. We want to balance the supply and demands of oxygen in the body. So a very common drug that is used in children with heart failure is digoxin. Digoxin has a pretty quick onset and is used, has primary use. Because of the toxicity with digoxin, we really need to be careful and do education over and over again with family on measuring the dose because of the narrow margin of safety. So we do a lot of education with parents or caretakers of the infants with digoxin before sending them home. Nausea, vomiting, bradycardia. So we do teach parents or caregivers to take the infant's pulse before administration, because bradycardia is one of the, we'd either hold for it or it's also a toxicity symptom. Difficulty feeding would also be another toxicity symptom. So for infants, those less than a year, we hold for a heart rate less than 90. And for children, those greater than a year, we hold for a heart rate less than 70. So we do teach parents and caregivers this. ACE inhibitors can also be used, so they decrease afterload, but we do need to be careful about the renal function with ACE inhibitors, because it can, the kidneys are very sensitive to ACE inhibitors. Beta blockers are used very selectively, so these are not our main go-to in children. CRT, that is the cardiac resynchronization therapy. So this is that biventricular pacemaker to ensure that both the ventricles are pumping at the same time to really ensure adequate cardiac output. Diuretics are used to decrease the preload in infants. Something that's a little different is fluid restriction is pretty rare in infants because many times they have difficulty in feeding anyways. So we really want to ensure caloric content. So they're oftentimes underhydrated. We may need to increase the caloric density of formula to ensure that they're getting the caloric intake that they need. If moms choose to breastfeed, it can be difficult for children that are, exhausted, infants that are exhausted with breastfeeding, so they will be supplemented with formula. In children, we do not tell them to maintain a low sodium diet. Salt can lead to stunted growth, decreased growth. So for the most part, children do not need salt restriction. Maintaining a neutral temperature to conserve oxygen demands is important. Semi-Fowler's position and uninterrupted sleep. So what I mean by this is try not to wake the child when sleeping because they really need to sleep. Only time we do wake them is for feedings, because we don't want these children, or infants rather, waking up starving, because it's going to be harder to feed them, and also if they're crying, it's going to, expend energy that we need to preserve. Talking about preserving energy, we really also need to be conscientious of using measures to keep infants calm. Sometimes with severe, heart defects, and trying to keep infants calm, because you can't just tell them go to sleep, right? They don't know any better. We will sedate them, so they'll actually get a mild sedative just to try to relax them so they can conserve energy. Those that are sent home, it's important to prevent respiratory infections, so good hygiene, especially from visitors. Making sure they get their vaccinations, those sorts of things. And that pretty much sums it up with our pediatric chapter.